Hello, my name is Ana Berni. I am an electrophysiologist from Mexico City. It's a great honor to participate in this meeting and have the opportunity to share knowledge with so many brilliant colleagues and friends. So, I've been asked to talk about highlights and key points of the recently published AF guidelines. The recently updated 2020 AF guidelines presented at the European Congress of Cardiology promote a shift from a single conventional classification of atrial fibrillation toward a structured characterization treatment decision making that facilitates communication among physicians of other specialties. This approach is based on the ABC pathway for integrated care management that stands for anticoagulation, better symptom control, comorbidity, and cardiovascular risk factor optimization. This integrated patient centered AF management should be accomplished by a team, including an electrophysiologist, a cardiologist, nurse, and general practitioner. These guidelines also include recommendations to measure quality of care and patient reported outcomes with the appropriate tools. So, the first step of the pathway is confirmation of clinical AF by a conventional 12 ECG or a single lead strip or ambulatory monitor or any wearable recorder ECG with at least 30 seconds of AF. Clinical atrial fibrillation may be symptomatic or asymptomatic. Subclinical AF refers to patients without any symptoms whose device, either pacemaker or ICD, reveals atrial high rate episodes without any documentation of AF by an ECG. Patients with clinical AF should be managed according to the guidelines. However, data on optimal management of subclinical AF is still lacking. Opportunistic screening for AF is recommended in patients older than 65 years of age. Systematic screening should be useful to detect AF in older than 75 years. One of the main novelties of these guidelines is the proposal of a structured characterization of AF, addressing specific domains with treatment and prognosis implications. This 4S AF scheme is aimed to facilitate the assessment of AF patients' treatment decision making and optimal management at any healthcare level. The 4S stands for Clinical Assessment of Risk of Stroke and Appropriate Anticoagulation Treatment. Symptom severity characterized by ERA symptom scale and quality of life questionnaires. Severity of AF burden, which is defined by the overall time spent in atrial fibrillation during an unspecified monitoring period. Finally, the temporal pattern, that is paroxysmal persistent, long-standing persistent, or permanent AF, may be associated with a higher risk of heart failure or all-cause mortality. Finally, substrate severity relates to atrial cardiomyopathy, fibrosis, and delay in electromechanical conduction. Non-invasive multimodality imaging such as echo, CT scan, or MRI can provide all needed information. We should remember that AF progression is related to the underlying substrate, and clinical factors such as age, hypertension, chronic kidney disease, diabetes, or previous stroke. Progression to non-paroxysmal AF is associated with adverse cardiovascular events, hospitalization, and death. So, the first step in the decision making ABC pathway is anticoagulation and avoid stroke. And we have to identify low risk patients who do not need antithrombotic therapy. Common stroke risk factors are summarized in the CHA2DS2-VASc score and are helpful to predict high risk patients who may sustain thromboembolic events. Other clinical factors such as renal disease, left atrium dilation, spontaneous contrast, obstructive sleep apnea, may be associated with a higher risk of thromboembolism, although they do not improve CHA2DS2 predictive value. Many biomarkers like troponin, peptides, and growth factors have improved performance over clinical scores to assess residual risk, stroke risk among anticoagulated patients. So the guidelines support the use of Hasbled score to address modifiable bleeding risk factors and to identify patients at high risk of bleeding. That means scores higher than 3 for early and more frequent follow-up. These assessments should be done regularly since both stroke and bleeding risk are dynamic and change over time with aging and comorbidities. In addition to clinical risk factors, many biomarkers have been studied as a bleeding risk predictors. However, the long-term advantage over Hasbled score is still on debate. So, oral anticoagulation is recommended for stroke prevention in AF patients with CHA2DS2 score higher than 2 in men or higher than 3 in women, and should be considered in patients with CHA2DS2 score of 1 in men or in 2 in women, based on net clinical benefit and patient preferences. DOACs, or direct oral anticoagulants, are recommended in preference to vitamin K antagonists, obviously excluding patients with mechanical heart valves or moderate to severe mitral stenosis. Antiplatelet therapy alone is not recommended for stroke prevention in patients with atrial fibrillation. High bleeding risk, which means Hasbled higher than 3, in the absence of absolute contraindications to oral anticoagulant, should not guide managed decisions. Clinical pattern of AF, paroxysmal, persistent, or permanent, should not condition the indication to thromboprophylaxis. Symptoms related to AF may range from known to disabling, such as shortness of breath, chest pain, or fatigue. Rate control is an integral part of AF management. Lenient rate control, which means less than 110, is sufficient to improve AF-related symptoms. Rate control is an acceptable initial approach as a background therapy in patients with no or minor symptoms, or as a therapy after failure of rhythm control strategy, and for those patients in whom risks of restoring sinus rhythm outweighs the benefits. AV node ablation should be considered in symptomatic patients with CRT and poor rate control in order to optimize biventricular pacing. Pharmacological rate control may be achieved with beta blockers, digoxin, diltiazem, verapamil, or any combination therapy. The choice of the most appropriate drug depends on symptoms, comorbidities, and potential side effects. Amiodarone can be useful as a third-line therapy, where heart rate cannot be controlled with combination therapy, or if the patient do not qualify for a non-pharmacological rate control, such as ablate and pace. AV node ablation should be considered in patients unresponsive to intensive rate and rhythm control therapy, and who are not eligible for ablation. Rhythm control strategy refers to any attempt to restore and maintain sinus rhythm by a combination of treatment approaches that include cardioversion, antiarrhythmic drugs, and catheter ablation. Integrated management of atrial fibrillation requires a multidisciplinary team for shared decision-making related to stroke prevention, rhythm control, and adequate treatment of comorbidities such as hypertension, diabetes, and any other cardiovascular disease. Clinical factors that favor rhythm control strategies should be considered. since early rhythm control interventions may halt progression of the disease. As we know, atrial fibrillation progression is associated with a decrease in quality of life, and with time, the substrate becomes more difficult to treat. For many symptomatic patients, an early intervention to prevent AF progression should be worth considering. Rhythm control therapy is recommended for the improvement of symptoms and quality of life. In hemodynamically unstable AF patients, emergency cardioversion should be performed. In stable patients, either pharmacological or electrical cardioversion can be attempted. Pretreatment with antiarrhythmic drugs can improve efficacy of elective electrical cardioversion. The choice of drug is based on the type and severity of the associated heart disease, such as LV hypertrophy, LV dysfunction, or ischemic heart disease, or even heart failure. When assessing the efficacy of a rhythm control strategy, it is important to balance symptoms and antiarrhythmic side effects. Catheter ablation takes a more prominent role for rhythm control and is now recommended to maintain sinus rhythm, improve of symptoms and quality of life in patients with paroxysmal or persistent atrial fibrillation, with or without major risk factors for recurrence. The Class 1 recommendation is based on results from the CAPT, AF, and CABANA trials. Catheter ablation is also now a first-line therapy for patients with atrial fibrillation who have a high likelihood of tachycardia-induced cardiomyopathy, independent of symptom status. In these patients, catheter ablation may help to restore left ventricular function. In selected patients with heart failure and reduced ejection fraction, catheter ablation has shown a reduction in all-cause mortality and hospitalizations for heart failure. In this group of patients, ablation also resulted in higher rates of preserved sinus rhythm and greater improvement in ejection fraction and quality of life compared with antiarrhythmic drugs. The cornerstone of AF ablation is complete isolation of pulmonary veins, either using point-by-point radiofrequency ablation or any single-shot ablation devices. Several risk factors, including AF duration and the presence of comorbidities such as hypertension, obesity, metabolic syndrome, and sleep apnea, may influence the outcome of catheter ablation. So, aggressive control of modifiable risk factors may improve arrhythmia-free survival after catheter ablation. It is also well established that cardiovascular risk factor burden and comorbidities significantly affect the lifetime risk of AF development. An unhealthy lifestyle and cardiovascular disease can contribute to atrial remodeling and development of atrial fibrillation. Identification and management of concomitant diseases and cardiometabolic risk factors is a key component of the ABC pathway. Intervention of multidisciplinary teams with a cardiologist, electrophysiologist, nutrition, heart failure team, nurse, and general practitioner, and of course, patient himself, is required to achieve treatment goals and better results. As a conclusion, let me tell you that atrial fibrillation is a progressive disease. Early management by a multidisciplinary team might help to improve outcomes. Anticoagulation, better symptom control, and comorbidities and cardiovascular risk factors are key components for integral management of AF patients. Catheter ablation is a first-line therapy for sinus rhythm maintenance and improvement of symptoms and quality of life. Early rhythm management may halt progression of the disease. Thank you for your attention.